the important thing is that we do have a test. We have a couple tests that we can evaluate minimal residual disease in patients that are commercially available. We can order those tests for our patients. As I mentioned, the results we do expect to correlate with outcomes, progression-free survival, and perhaps overall survival. So if a patient finishes a year of venetoclax plus obinutuzumab as a frontline therapy, we are measuring MRD status at the end of that year. And to determine if a patient's MRD negative or undetectable or not. If a patient's undetectable with regard to MRD, again, we don't do anything different with those patients, but we can be comfortable with having a conversation with our patients that they've achieved a good remission, a deep remission, and that their remission duration should be several years. If they're MRD positive at the end of that fixed duration of treatment, the conversation I have with them is, we need to watch you closer. We need to think about what the next steps are. And we use this information in terms of planning, longer-term planning for the patient's management, because we do anticipate a shorter remission for those patients who are MRD positive at the end of treatment. So again, we don't have data to intervene or do something different. It's more informative for a patient at the end of a fixed duration treatment. We're also gathering information, monitoring MRD over time in a treatment-free period, just like we monitor the white blood cell count to see how things are changing. That's not standard practice. That's something we're doing in clinical trials, and we're working on generating data to inform us how that might also be helpful. I do anticipate in the future, we will have MRD-directed treatments where we're measuring MRD status, and our management and treatment will depend on what the MRD status, whether we're giving patients more treatment or we're stopping treatment early if they're undetectable.